So I've been working on the subject of obesity for the better part of 2 decades. It's something that affects me personally. It's affected everybody that I care about, really. Today, there's even a tendency to think that if we could just educate people who don't admit to themselves that they have obesity, then that would solve the problem. The real impact is that people start to believe the lies that people are telling about them. They start to believe that I am less than. They start to believe that there is something wrong with them. To overcome weight bias, you have to understand what obesity really is. It's not a behavioral problem. It is a biological problem.
Okay, it is my great pleasure to now hand over the stage to WISH TV medical expert, Dr. Janel Gordon, for our next discussion.
Hello, everyone. Thank you, Dr. Pashby, for introducing me again. I am Dr. Janel Gordon. I am a triple board certified family, obesity, and lifestyle medicine physician. I also have the pleasure of being the medical expert for WISH TV. And I just want to thank the patients for sharing their story. Like Dr. Pashby said, for some of them, this is their first time, and we are privileged that they were even vulnerable to share what they've experienced with us. And I want to take the time now to introduce the panelists who are with me here today to take a deeper dive into the societal and human impacts of the disease obesity. So I have next to me Dr. David Allison, who is the Dean for the School of Public Health at IU School of Medicine. I have Dr. Lindsay Weaver, who we know is our Indiana Health Commissioner, and Dr. Virginia Caine, who is the Director and Chief Medical Officer for the Marion County Public Health Department, as well as the 125th President of the National Medical Association. Thank you all for joining us here today. So let's get started. Dr. Allison, can you please discuss with us the scope of obesity and its effects in the United States today?
Certainly. We know that obesity affects many of us. It is literally millions of people. The numbers change a little bit from time to time, but it's on the order of more than 50% of the United States population being either overweight or obese or, thank you, or ever-increasing numbers of severe obesity as well. So obesity has been increasing for several centuries. There is often a statement of what happened in the late 1980s because we saw the NHANES, the National Health and Nutrition Examination Survey data, jump from the early 80s to the late 80s. But in fact, if you really look at long-term data and also data on skin folds, you can see the data on skin folds jumped a lot earlier than that, and BMIs and obesity levels have been increasing for literally hundreds of years, but they have accelerated a bit. Severe obesity has increased tremendously. What used to be an incredibly rare body weight to be able to find anybody for your studies is now more than 10% of the population having a BMI of 40 or greater. It is associated with stigma. You've heard a lot about that in the last session. One of the best things we can do is to be kind and to try to reduce that stigma. A lot of that is tied to social class, to racial issues, to gender issues, to age issues, where stigmas are compounded. We know that it affects medical health, physical health. It reduces longevity on average. Again, not everybody's a ticking time bomb, as you sometimes hear. The effect on longevity is moderate for most people, but or for most groups, but it is clearly there. We now know for the first time that we have treatments that actually will extend longevity. I could not have looked you in the eye and said that with honesty 20 years ago, but I can today. And it started with bariatric surgery, and then the SGLT2 inhibitors, and now the GLP-1 related drugs, and those have unequivocally been shown to reduce mortality rate, not just cause weight loss. So we've got a lot to work with, but we've got some new tools, and it's an exciting time where I think there is hope where there was not hope before.
Thank you. Dr. Caine, could you share with us your perspective?
So sadly, we know that 108 million Americans now beat the definition of obesity. And it's predicted that by 2030, 50% of the nation will fit that definition. But unfortunately, when we look at some people of color community, especially the Black community, we are already meeting that mark of 50% of the Black community are obese. And if you look at the Black female, at least 54.9% are obese. So it's some incredible impact that we're seeing in certain vulnerable populations, whether it's related to social determinants or different lifestyles that impact everyone. And we cannot forget that income and social status plays a major role in this.
Let's dive deeper into that and discussing the social determinants of obesity in this country.
So we know that obesity is associated with socioeconomic status. That's probably one of the chief ones, but not the only one. But often the story is more complex than that, and it goes, I think it highlights the importance of an open mind. We often hear pundits say things like, obesity is selectively a disorder of the poor, and also will tie that to minority status. And my good friend and colleague, David Hayes Bautista, who writes about ethnic differences in health and dispelling myths, talks about how the common narrative of minority status leads to less education and material income or resources, which then leads to less healthy environment and health care, and that leads to lesser health, is just a plain old-fashioned oversimplification. And it just does not characterize, for example, the Hispanic paradox, where many Hispanic populations are healthier and have better outcomes on most disease states than non-Hispanic populations. It doesn't take into account the fact that the association between socioeconomic status and obesity, which is reliably inverse in adult white women. In other words, the richer and more educated an adult white woman is, the less likely she is to be obese, is true for adult white women. There's virtually no association between socioeconomic status and obesity among adult Black women. And as you go to different groups, things differ. We heard from Dr. Caine the marked higher prevalence of obesity among African American women. But among African American men, the prevalence is extremely similar to what it is for European American men. Whereas for Latino people, both men and women have elevated levels of obesity. So we can't have simplistic explanations. There is something going on there, but it's not as simple as we often like to paint it. There are also, particularly pertinent here in Indiana, a big rural-urban divide. So there is probably no population that is more disadvantaged these days in the United States than is the rural population. The rates of obesity and diabetes are tremendous. You may think that the capital of the world for prescriptions for GLP-1 related weight loss drugs might be Hollywood. It turns out to be a rural area of Kentucky, in which has the highest per capita prescriptions of those drugs. Obesity has increased more in the rural areas than anywhere else in the United States in recent years. Decades ago, my friend Arlen Price did a wonderful study. He got the old Iowa adoption data from Professor Remy Cateray and looked at people who had been adopted, children who had been adopted into rural homes versus urban homes. And the adoption, which home they get placed in is semi-random. And it turned out that those adopted into rural homes grew up more likely to be obese than those adopted in non-rural homes, suggesting there is something causal about the rural environment that leads to more obesity. So those are just a few of the socioeconomic factors that we see.
Okay. Dr. Caine?
Well, let me just make it simple for all of you. How many of you belong to a gym club? You want to raise your hands? How many? Okay, I'm seeing quite a few hands. So now if you're in the lower socioeconomic bracket, you don't even make living wage. What do I mean by living wage? That you have enough money to pay for your rent, put food on your table, and you can have electricity. But how many of those low-income clients could afford to go to a gym club for physical fitness? And let's just say, where do you live? A lot where you reside makes an impact on your longevity. So if I'm in let's just say in inner city, some type of our communities that have no sidewalks, so if I'm gonna do my physical activity, I gotta walk out in the streets. Or let's just say the crime area might be a little bit higher than we might see sometimes in our suburbs. Who wants to walk out there and put themselves at risk that some stray bullet or somebody might mug me in terms of our activity? But I like the one that's the best where, wow, what's the closest grocery store that I live in? So that a lot of times I have to go to the gas station. They serve a lot of processed food sometimes. I sure can't get any fruits and vegetables there. But my doctor, my healthcare professional, is trying to chastise me because I'm a diabetic and I'm not eating properly. So when did you get your fruits and vegetables? So if it's in the winter months, it's snowing, I got 3 kids with me, for me to make it to that grocery store on just the bus transit, what kind of load of groceries can I carry? And it take me an hour to get to that grocery store. And I can only bring so much back personally to get back to my house. So I think we have to have a more realistic idea of what it talks about social determinants, whether I've got food insecurity taking place, or what the landscape of my environment is, as we're trying to educate people, but provide them the resources and the tools in order to maybe have some activities that can benefit us. I don't know in the rural areas how many boys and girls clubs that may be that their children can access at a low cost. So I just think that we really have to change this paradigm shift and look how we are able to bring the resources to our clients. And we're always forcing our clients to come to us. But now, if you don't have any insurance, you know the biggest problem if you don't have insurance. Now, you won't believe this, but I had a little kitten that I tried to help the Indianapolis coach because she tackled me on my second floor and I fell, tore my meniscus on my knee, herniated my back, tore both my left and right shoulder deals. And so I was put on this wonderful osteoarthritis medication for my knee. And so I went to a pharmacy place to just get 30 tablets a month, just 1 tablet a month. And I didn't have my prescription card with me. So the pharmacist said, well, you sure you want to buy this prescription? I said, sure, I'll just pay for it out of my pocket. $220 for I thought, 30 pills? Are you kidding me? So you know I had to get back in my car and go home and get that prescription card. But think about the folks that we have out here who may have obesity, who may have diabetes. They don't have that group discount in order to pay for their medications. They have to pay the full retail cost. So we have to understand that we have a significant vulnerable group of people that if we're going to address obesity in this country, we have to look at the whole perspective and add social determinants as part of our model for making a difference with our populations.
Thank you. Dr. Weaver, as the Indiana State Health Commissioner, can you talk to us, hearing what Dr. Allison and Dr. Caine has said about the difference for Hoosiers in rural areas versus urban?
Yes. First of all, I do want to also thank our previous speakers. We talk a lot about rates and percentages, especially in public health, and something we always remind ourselves of, and why I'm so glad that those 3 people took the time to talk to us, is there's real people, real families, real lives behind each of these numbers. So my personal thanks to them. When we are looking at our rural communities, there is a significant difference. One of the things that we recognize is when you see obesity percentages, when you look nationwide and they're comparing state to state, and we know, if you've ever heard me talk before, Indiana is ranked 7th, which is not good. We're tied with Iowa as the 7th most obese state in the nation. But all of those data points are utilizing survey data, which we know not to be true. Research has guesstimated that it's about 10% off. We know as we're implementing new programs, while we have new drugs available across our state, we wanted real data, so we weren't relying on people answering, one, picking up their phone, and who does that anymore, and 2, answering questions on their height and weight. We needed real data. So now for the first time in the state of Indiana, when you go to our website and you see our obesity rates per county, that is based on real, true discharge data where someone has been diagnosed officially with that, not somebody just, answering questions on a survey. We thought that our obesity rate here in Indiana was 35%, and that's what you'll see when you look at national information. It is not. It is 42%. We thought that our most obese county was Miami County at 40%. It is not. It is Vermilion at 51%. So Hamilton County, which is Carmel, just north of here, right, 35% obesity rate. Vermilion County, 51% obesity rate. And when you look at what are the most obese counties, who are those that are ranked the worst, it is primarily our rural communities. So excluding, the donut counties around here and some of our more urban and suburban communities. When you go to those communities and you talk to them, they are not surprised. When we thought Miami was our most obese county, and I tell this story often too, and we were like, sorry, you're the most obese county. It was actually the sheriff that raised his hand, and he was like, half of our county is shopping at a gas station. There is no access to a grocery store, half of the county. And if you have low socioeconomic status and you're trying just to live, paying the additional money to get in the car for the gas to go there, or if your family has only one vehicle, it truly becomes an issue. And so it's working with those communities to really kind of they know best what is going on in their communities and how it is best to address it. And it's going to be one community at a time. It's the Boys and Girls Club, it's the access to the Y, is it sidewalks, is it just access to fresh food, right? And not shopping at a gas station. And that's why, we're so excited about the work that we're doing to really dig into all those different issues.
Thank you, that's good. You mentioned sidewalks, walkability, communities, even public transportation. Like thankfully here in Marion County, we're doing a lot with the bus lines, but if you think about these rural areas, they don't necessarily have that. They may have to depend on family or friends to get them from point A to point B, or money for like an Uber or Lyft if they're even out in those counties. So we have to, as healthcare providers, think about all of these different risk factors that could increase someone's possibility of having this disease. So Dr. Caine, could you please discuss the connection between obesity and other metabolic conditions and the awareness or lack of awareness of long-term complications of having obesity for us?
So I think some of our prior speakers alluded to some of that, where not only do you get type 2 diabetes, which we used to see a decade ago in their 50s or 60s, we're now seeing it at a much younger generation and even teenagers, but you can also get that fatty liver. She was saying, one of the panelists, I didn't get my liver enzymes test, but you can get that at a much earlier age. And it can also, besides the type 2 obesity and the diabetes, complications of diabetes can result in amputations, diabetic foot infections. It can impact kidney failure. We can also see as a result of the obesity how it impacts even infant mortality. We know that mothers who do not breastfeed has a higher risk of their children having obesity at a later stage. So it has huge complications, especially as it relates to the heart and heart disease, which now is our #1 killer. in regard to the diabetes. So you may have.
Yeah. So multiple different types of cancer. To go back to the infant mortality, a mother being overweight or obese in of itself is a risk factor for higher infant mortality. Baby being born preterm, gestational diabetes outcomes, et cetera, and a higher risk for maternal mortality, which are also things where we unfortunately do not do well with here in Indiana, and no doubt that they're all related. I will say too, like you were talking about increased risk of infection. I was just recently talking to a bunch of respiratory therapists, and they were talking about how difficult it is to ventilate somebody, to intubate somebody, right, who is overweight and obese, totally separate than whatever disease process or surgery that they're needing. That in and of itself makes those procedures that much more risky. As an ER doc, I mean, lots of complications that we worry about, and it just makes it difficult to do what we need to do when someone comes in with just being obese, but also all the other risk factors that come along with that.
And one other thing is that, you know, it's going to be so important that precision medicine is making a play. So when you're given different medications based on the weight, what's the absorption rate of that drug in that person in terms of its effectiveness? What's the ability in that particular person to excrete that particular medication? So the efficacy can change based on the weight of that individual. And you have to have enough studies in order to make a difference. So when we were looking at the COVID-19 vaccine, in the makings of that, did we have a significant enough number of patients who were obese so we could detect the efficacy of that and the duration of the protection, because it could be different.
And when you speak about precision medicine, we have to talk about the diversity of research participants in these studies when we're trying to bring these drugs to market. Because what may work in me may not work as well as you. And so there needs to be a larger push for diversifying your participants, just to the founders out there. And I also wanted to hear from you, Dr. Allison, your thoughts on this.
Sure. Well, I think that what's been said is apt, and I strongly agree with it. I'll pick up on some of a slightly different tact, which is I'd just like you to imagine something that's not all that hypothetical. This is an experience I often have. I go to some party somewhere or a potluck in the neighborhood, and I'm meeting some people, and somebody says, "What do you do?" And I have a few different answers I can give. If I'm feeling a little introverted and don't really feel like talking that night, I say, "I'm a statistician." And then that just kills it. There's no more conversation. But if I want to talk a little bit, I say, "I study obesity." And then the conversation just goes. And it doesn't matter if this person has no medical training, has never written a scientific paper, never read a scientific paper on obesity, has no training in nutrition, no training in any science, no training in psychology, nothing. I am going to hear their theory of obesity. And I'm going to hear it with confidence. And they're going to tell me that we have obesity because of, fill in the blank, not enough PE in the schools. And the treatment is we need more farmers markets, or we need more walking trails, or we need whatever it is they think. That degree of confidence is extraordinary. Now, if I said to them, what I study is the beta cell of the pancreas, do you think that anybody would actually say to me, "Doc, I don't know anything about beta cells of pancreas, and I'm not a diabetologist, but let me tell you my theory"? I don't think so. With respect to obesity, we need to treat it much more like a serious science and stop making assumptions and so on. And the health effects is just one of many examples where we could pick this up. But an example would be osteoporosis. We might, we heard about obesity affecting cancer and heart disease, and those are all true. We might think, and we used to say, obesity is actually protective against fractures and osteoporosis because you have weight bearing, so that strengthens the bone. Adipose tissue produces estrogens, so that strengthens the bone. And you have padding, so if you fall, it pads you, right? All of which is true, except the part where that leads to less fractures, because it doesn't take into account other factors, like that the structure of the bone is different in obese people, such that even with the same amount of mineral, it may be less strong. It doesn't take into account a more sophisticated understanding of the engineering and the physics that yes, you have more padding when you land on your hip if you're obese, but you have more mass pushing on that hip, and force equals mass times acceleration, and guess which wins. So, greater issues there, greater likelihood of a pubic bone fracture in an obese child whose vehicle is hit from the side. So there are many other ways that obesity affects things, and we need to be open-minded to the science of it and not just get involved in our assumptions. And some of these things are things where we can help. For example, my group and others have shown that after a vehicle collision, even if you control for the type of car and whether someone was wearing a seatbelt and to the best of your ability to discern the speed and all those things, obese people are more likely to die after being in a vehicle collision than are non-obese people. Why is that? Well, it turns out we've done some real serious engineering simulation work on this, and it's mostly true in men, so not so much in women, and it has to do simply with the physical, where the mass is and how that drives people's heads into steering wheels and things like that. Well, once you do that, you can feed that information back to the engineers, and instead of just saying our solution to everything in obesity is move more, eat less, lose weight, is say, how about we redesign the environment a little bit for you and make the vehicle safer? And that's something that I think we need to be open-minded to.
That's good, especially from a societal standpoint. I think my mic is working. For all of you, starting with Dr. Caine, we know that Hispanics and Black Americans have 2 times the rates of obesity. Can you speak to some of the reasons why and then even possible solutions for these groups of the population?
Well, I do think that, let me just talk a little bit about policy. There's a study that's done by Wisconsin that looks at different risk factors for every county in every state. And in 2021, they showed that our obesity rate for Marion County was like at 38%, but when I compared myself to Chicago and Illinois, they only had an 11% obesity rate. And I said, well, wow, you know, how is Chicago so diverse and all those different populations have an obesity rate of 11%, but Marion County is at 38%. So I do think sometimes policies make a difference, health policies. So in Illinois, it is a requirement for every school system to do physical activity for their children. That's not the case here in Indiana. You know, you can do study section and get out of physical activity if you could. So I do think that we have to look at those places where the obesity is low, but our populations may be representative at the same time to see what are they doing differently, what are their resources that they are doing. But I think in terms of talking about solutions, we have a wonderful program where we're able to have the doctors participate, where they can write a prescription if you're diabetic or if you're obese, where you can go to a pantry, certain pantries, and get free products that are specifically designed for, if you're a diabetic, these are the products that you should only be looking at because it's best for your glucose control. Or if you're obese, these are the better products and healthier products for you. And we're even doing a lot of education with the pantries to say, you know, we love for people to donate food to you, but we want it to be healthy food that they donate. And I think you can educate them. So 75% of our pantries now in Marion County are only accepting healthy foods. They're having health educators in those pantries. And we have a program too where we pay clients who are low income. We subsidize them, provide them over $200 and some, and they can use this coupon to purchase healthy foods like fresh farm markets. And we identify resources close to where they reside. So there's some great activities out there, but I've got to give a plug, if she doesn't give the plug, to our Indiana state policymakers. They were incredible in funding what we call Health First Indiana, that will allow rural communities, other places, in order to provide the dollars and resources in order to make a difference, especially where it can be addressing some social determinants of health.
To expand on Health First Indiana a little bit, I mean, the whole point of Health First Indiana is all these communities are able to come up with their own solutions. Let's be real here. Obesity is complicated, right? So Dr. Allison will tell you that there is a study that shows that, you know, prevention, individual kind of prevention practices in kids did not show some success. But when you actually dig into the data, about 25% of the time they were positive, and it basically comes down to it's complicated, right? You can't control for every factor of these different individuals in these different, you know, program implementations to see, you know, is this going to really make a difference from preventing our kids, which a third of our kids here in Indiana are overweight and obese, right? 2/3 of our adults are. So I always tell people, how are we going to keep that 1/3 from growing to the 2/3? It's going to have to take a multimodal approach. And it can't just be a program just for the kids, right? Even though kids are in school for 6 to 7 hours and we can control that there, what's happening after school, what's happening at home, what's happening on the weekends, right? We have to be able to bring the parents and the families into this and recognize that, you know, some of the most successful like weight loss clinics, et cetera, working with physicians, they're multimodal. You have your primary care provider, maybe you have a cardiologist, there's a nutritionist, exercise is a part of it, a clinical pharmacist to make sure that you have really good, you know, control of the medication and updates are made to it for that individual. We should be taking the same approach to this when we're talking about kids in different communities, right? That it's going to take many things. Can we get the good food there? Do you have access to physical exercise? If we give you the good food, do you know how to cook it? Which, as we started on this process, that's what many of my teams across the state found out. They're handing them the healthy food boxes and they would come back and I have no idea how to cook it. So then they said, okay, here's some recipes. And then they found out they don't even have the equipment at home to know how to to be able to make the food, right? And so it's kind of like keep on asking questions and keep on addressing it. But there is some things to this, right? Even though you may look at the studies and say it doesn't work. We know that we're on average eating about 500 more calories a day than a couple of decades ago, primarily in grains and cooking fats. So we have to look at our food, right? What are we putting in our mouths every single day? It's not just more, but what type of food is it? You can look at the pandemic when you're talking about our kids. And during the pandemic, when they were in and out of school or out of school, the rate of BMI increase doubled, 2.5 times actually during that time. So something that was happening at school was helping control that, right? Or was it the stress of being at home? And I know I didn't feed my kids very well at that time. So we really need to be, and I think to Dr. Allison's point, right? We needing to be thinking outside the box and not thinking there's just simple solutions here. There isn't, never in medicine is it just one solution, right? It's gonna take all of you, all of us, to really say, what is that wraparound approach for our kids and our adults who are suffering with this disease, and prevent people from ever having the disease in the first place.
Right, prevention is key.
I did quite well.
No worries. I agree with much of what's been said. I think it is true that the current prevention efforts in community, school-based things have not been shown to be terribly effective, but that doesn't mean that there couldn't be prevention efforts that would be shown to be effective, but we haven't yet found those and instantiated them well. I think what we need to be careful of is not continuing to think inside the box when we've shown that it has, at best, limited value. It reminds me of the 19th century beginning of epidemiology, when one of the first real epidemiologic studies that we would recognize as such today was on bloodletting, and in which somebody who thought bloodletting was a good thing for treating various diseases, to his credit, pulled together a lot of data and showed no association between more bloodletting or using bloodletting and recovery. And one might think the conclusion would be, let's stop bloodletting. But in fact, the conclusion was bleed more and bleed harder. And I think that's where we are with some of the prevention, as opposed to saying, try something out of the box. Now, I was really struck by two words that Dr. Caine used that were very powerful for me. She said safety, and she said security, and talked about how lack of those things might be problematic, and I would agree. There's an interesting study from the Department of Housing and Urban Development called the Moving to Opportunity Study, MTO. It was a very large, government-funded, randomized controlled trial in which persons who lived in so-called poor neighborhoods were randomized to either get housing vouchers to go move to less poor neighborhoods or not. It wasn't an obesity study. It wasn't a diabetes study. It didn't involve giving them fruits and vegetables, nutrition education, enjoinders to exercise, walking trails. It said, here you can move to a safer neighborhood and you have some financial security as a result of those housing vouchers, right? No money in the pocket, but housing vouchers. And lo and behold, decades later, as published in both New England Journal of Medicine and Science, women and girls assigned to the households which got housing vouchers were less likely to have diabetes and less likely to be obese. There have been a couple of other studies slightly similar. In the interest of time, I won't go into the details, but which suggest that general education, not nutrition education or metabolic or physical activity, general education seems to at least be associated with and maybe cause less obesity and less diabetes, especially in women and girls. It may not work quite as well for men and boys from what we see. But to me, that is the kind of out of the thinking box we really need. Give people security, give people safety, give people a feeling that they're part of the world, that somebody's caring for them, give some parent training early on. And these things may be far more powerful than giving walking trails and fruits and vegetables.
I had the honor of listening to some recent testimony over at the State House, and one of the pediatric gastroenterologists from Raleigh Hospital provided some startling information where they had followed a large number of young children who were overweight, significantly overweight, and they put them on an intense diet and an intense physical fitness program where they were able to closely monitor what they ate, as well as providing them snacks after hours. And despite 6 months of this intensive regimen, they found such a large number of the children didn't lose enough weight to make a difference from a life-saving standpoint of major complications, and noted that in order for them to be successful in addressing their obesity, that it would have to be nutrition, physical activity, plus a medication in order to be effective. And so when you think about this, and even for adults, the frustration of, wow, I'm out there, I'm really walking, and I'm eating right and everything, and I just can't seem to take off this weight, but I'm doing everything they told me to do, but it's not making the huge dividends for all the investments that I'm doing. So I think we have to really strongly relook at this communications that we're doing. And you know, with that weight loss that we people, especially young children, that get bullied in from schools, you know, it creates to so much eating disorders because, whoa, you know, I'm dieting all the time and it's not working, and so that's reinforced. And so I think we need those new studies that you talked about, Dr. Allison, to show that whether it's a certain genomic expression, so my genomic expression is different than hers, okay? And so I have a sister, I mean, my goodness, she eats like nobody's business, and she doesn't seem to gain a pound. I know she doesn't gain a pound because I sometimes go to her medical visits. And yet, I can eat something, a pound or two, doesn't seem like I even ate a lot. And I'm saying, where did this weight come from? I just don't get it, because I know I'm doing the walking. So sometimes it is genetics, and we have to continue to do more studies to try to identify those proteins or whatever that may damper my absorption. It may impact my metabolic activity. You know, I know it slows as you get older, but you know, somebody may have some built-in high metabolic energy there that we need to figure out how to tap that and maybe, you know, include it as some newer medications maybe.
That's good. And I think it's important that we stress that to our patients and individuals who we interact with in the community, that obesity is a very complex disease. It's not like you said, just eat less, move more. And the solution is not just one thing. It's not just medication. It's not just changing how you eat. It's not just changing how you move your body, getting restful sleep. We have to look at all of that, and we really need all industries to play a role as well. Big pharma, big food, government, et cetera. So as we close out, if you all could just briefly speak to how you feel like the stigma associated with obesity is changing, especially in comparison to other diseases such as HIV or even depression, anxiety, et cetera.
Sure. So the very first paper I ever published was when I was a master's student, and it was the development of something called the Attitudes Toward Obese Person Scale and the Beliefs About Obese Person Scale, and we studied this stigma back then. So it's something that I think we knew about then and we know about now, and much data have been collected. And on the positive side, there is evidence that stigma has been reduced, and that's good, including among healthcare providers, and that's good. There's also, however, clear evidence that it hasn't even come close to going away. So there is still a lot of stigma out there. Obesity is one of the few conditions where it still seems socially acceptable to many people to stigmatize and mock persons with obesity, whereas they might not think it was socially acceptable to stigmatize and mock other groups. So I think we have still some work to do. I've seen with the GLP-1 agonist, now this is anecdotal, but is my sense of things, an interesting thing where I think things have gotten slightly worse in some ways, but then may get a lot better later. Often things get a little worse before they get better when something causes a little change, a little stirring. And I see what I think many might call a moral panic, which is the idea of, you know, if you take somebody like myself, I managed to maintain a body weight that's what I want roughly, and most people would consider low enough. But it's really hard, and I work really hard at it. And I'm hungry a lot, and I, you know, I'll exaggerate, but I quote unquote suffer. And then I look at somebody else, oh, they got to be thin, and they took a pill. They didn't have to suffer. That's not fair. Everybody has to suffer, right? So I think this kind of moral panic we're seeing when you hear people talking about, well, when they stop taking the drug, the weight will just come back, or they just want to look better, as the idea of, and wanting to look better is a sin. The people aren't entitled to look and feel better. So I think we're seeing that moral panic that we don't see with statins for cholesterol or antihypertensives for blood pressure or any number of other things. And I think the availability of these things will accelerate the discussion. And that spike we're seeing now, I'm seeing now in these pejorative statements will reverse, and we'll start to see obesity more as a treatable condition and persons' feelings as mattering, and I think stigma will come down further.
This is the fifth talk in probably 2 months that I've been asked to come speak at about obesity, and I'm thrilled, because in my career, it's something that we would maybe talk about behind a patient's back, right? We knew why they were having these complications, but we were never addressing it with the individuals. There's not a single person in this room hasn't been affected personally by obesity, whether it's yourself, your parents, a friend, your work that you do. So the fact that we're talking about it, and we are talking about not about it as in like it's a choice, but that it's a disease, to me has been a game changer. I think people are becoming more aware that it's not just diabetes and high cholesterol that you might get. They recognize that, wow, this is affecting so much more of my life. It affects our economy, it affects education, it affects mental health in kids and adults, and there's so much opportunity there. I'm really excited for the future. I really am. I mean, this train has just been going faster and faster in the wrong direction, and I do feel like we're about to make a turn. I really do. And I think, I'm really proud to be here in this state, and of course I go to sleep thinking about Indiana, and I wake up thinking about Indiana, and then my kids, just kidding. But I think we can do it here in Indiana, right? I think we can start to make that difference, and it's because we're going to continue to have conversations about like this. Final word, Dr. Caine?
Well, I think the excitement for a lot of our health professionals, especially in my medical association, that we saw the reduction of cardiovascular disease by 20%. And if you just looked at myocardial infarctions in one study, 28%, and strokes by 7%. That is just so, it's just so remarkable. But I'm also excited about how the dialogue is changing, from our patients to us as healthcare professionals, where we need to push more. You can be healthier based on a different weight. I'm talking about health. I'm not talking about, I'm giving you this information because you're obese. I think that there's a different nutrition or message no matter what your weight is, and you can be healthy by that weight. So I'm trying to get rid of the word obese. But, how can we be healthy just in general overall? And we talk and emphasize that. What are your goals? What are your lifestyle things? What can we prevent in terms of more of a wellness approach as opposed to an obesity approach? And so I'm only getting this information because I'm obese. And when I look at the HIV, because I am an infectious disease physician, we had a tremendous amount of stigma for HIV. We still have some, but with so much education out there, it is really improved. But a lot of times still, if someone says, I want to give you an HIV test, well, some black patients may say, well, what are you trying to say about me? Am I permissive or something like that you're asking me for an HIV test? I'm married and, I don't appreciate this. But, you can use another approach. You can just look at those cities that may have a really high incidence of HIV. And you're saying, hey, because we're a city that's got this high incidence and high prevalence of HIV, this is the recommendation we do for everybody, no matter who you are, what city you are. We don't care about what your sexual orientation or your lifestyles. This is just only making this recommendation based on geography and data. So I think there's some really innovative approaches and communication pieces that we can do with more focus groups and talking more to our patients that can make a huge impact with results. So I look to hear from all of you, new studies, new research, new focus groups, new solutions for us, but it's about the dialogue and listening to communities that can make a difference.
That's good. And I think if individually and even as healthcare professionals, if we think about the positive things we can say. Oftentimes people think about healthcare and, I don't want to go see my doctor, I'm going to get his bad news. If we talk about what you can add instead of taking away, not necessarily restricting your nutrition, but if you eat these foods, this can improve your health in this manner. And no matter the weight, right? So I want to thank everyone for joining us here today. I hear that we're taking a 15-minute break so everyone can get up and stretch, because we know how important physical activity is, and getting fresh air and sunlight boosts those vitamin D levels. And then we'll come back to talk about the future of obesity care here and globally. Thank you.